Okay, so let's talk a little bit about body fluid regulation within the body. So the volume of fluid in the body normally stays fairly constant. So the most common example of a fluid imbalance is dehydration, a condition that occurs when a person does not take in as much water as he or she loses. It's important to remember the role that insensible fluid loss plays. So this is the loss that's through our lungs, our skin, sweat, and feces, and this accounts actually for a significant amount of fluid loss each day. So homeostasis is maintained through four main mechanisms. We have the kidneys, we have anti-diuretic hormone, ADH, the renin-angiotensin-aldosterone system, and atrial natriuretic factor, ANF. So the first line is our kidneys, and the kidneys adjust the reabsorption of water from our plasma filtrate, and ultimately they control the amount that is excreted as urine. So although 135 to 180 liters of plasma per day is filtered by the kidneys in an adult, only about 1.5 liters of urine is excreted. Electrolyte balance is also maintained by the selective retention and excretion by the kidneys. The second mechanism is antidiuretic hormone, ADH. So when serum osmolality rises, so this is when the fluid in the vascular system becomes more concentrated, ADH is produced. So what does antidiuretic hormone do? It stops diuresis. So it keeps the kidneys from excreting water. So when you think of ADH, think of water. So ADH causes the collecting ducts of the kidney to become more permeable to water, which allows more water to be reabsorbed into the blood. And as more water is reabsorbed, our urine output falls and our serum osmolality decreases because the water dilutes the body fluids. So conversely, if the serum osmolality decreases and the body fluids become less concentrated, ADH is suppressed. So the collecting ducts become less permeable to water and our urine output increases. That excess water is excreted until our serum osmolality, so our normal body concentration, returns to normal. Okay, our renin-angiotensin-aldosterone system. This system is based on blood flow rather than blood concentration. So we have specialized receptors in the kidney nephrons that respond to changes in renal perfusion. So this initiates the renin-angiotensin-aldosterone system. If blood flow or blood pressure to the kidney decreases, renin is released. Renin causes the conversion of angiotensinogen to angiotensin 1, which is then converted to angiotensin 2 by our angiotensin converting enzyme. And then angiotensin 2 acts directly on the nephrons to promote sodium and water retention. So when you think about the renin-angiotensin-aldosterone system, you have to think about water and sodium. Okay, in addition, it stimulates the release of aldosterone from the adrenal cortex, and aldosterone also promotes sodium retention in the distal nephron. Angiotensin 2 also acts on the blood vessels themselves and causes vasoconstriction, which increases our blood pressure. And it also acts on the hypothalamus, which tells you that you're thirsty and that you should try to increase your fluid intake to help your blood pressure. So the take-home message here, the net effect of the system is to restore blood volume and renal perfusion through sodium and water retention. So remember, as you learned with osmosis, if we retain extra sodium molecules, we're going to retain extra water. Water is going to follow that sodium into the vascular system to try to keep everything in equilibrium. So this will cause an increase in fluid in the vascular space, which will increase blood pressure and increase perfusion to the kidneys. So again, aldosterone, think about reabsorbing sodium and water, and this increases total fluid volume. Whereas with ADH, we reabsorb water only, and this dilutes our overly concentrated body fluids. So the renin-angiotensin-aldosterone system has to do with body fluid volume. ADH has to do with body fluid osmolality. Okay, so then we have atrial natriuretic factor, ANF. This is actually released from the atrium of the heart when there's too much blood volume in the body. So the extra volume causes extra stretching of the atria, which causes the release of ANF. Then ANF acts on the nephrons to promote sodium wasting. What happens if you're losing sodium? Due to that osmotic pressure, the sodium pulls water out with it. So the net effect is to reduce vascular volume. ANF also inhibits thirst to reduce fluid intake. So fluid volume excess. This is when there is just too much fluid in the body. This can happen because you infuse way too much IV solution, or there might be a problem with one of those homeostasis mechanisms that we just went over. This is going to lead to hypervolemia, which is just a term that means too much fluid within the blood vessels themselves. And it can also lead to edema, which we know is too much fluid in the tissues. So some of our causes of fluid volume excess. So we have congestive heart failure. So in this case, the heart cannot pump blood effectively and it backs up into the body. If it's left heart failure, the blood backs up into the lungs. So some of the things we may see with CHF, you have edema, you have jugular venous distension, which is showed in the picture on the slide, maybe some pulmonary edema, if that excess fluid is leaking into our lungs. Shortness of breath and hypoxia would follow that. And you might see some nausea and some weakness. Then if we have liver cirrhosis, cirrhosis is scarring of the liver. So fluid volume excess is due to two mechanisms. We have portal hypertension. This is when we have increased pressure in the venous system that carries blood from the stomach, intestines, and spleen to the liver. And we can also have hypoalbuminemia. So this is a low level of the protein albumin in the blood. And albumin is the predominant protein that helps maintain blood volume. It's reduced in cirrhosis, primarily because the damaged liver is not able to produce enough of it. But without the albumin, there's less colloid osmotic pressure in the vascular system, so that fluid that's pushed out of the blood vessels by our blood pressure in the capillary beds, it does not get drawn back into the blood vessels. So the result of this is edema. Then we have adrenal tumors. These can cause hypersecretion of aldosterone, which causes the body to retain sodium and water. And then the final cause would be over-administration of fluids. So if we are just giving them too much fluid, we can overtax their system. That excess fluid has to go somewhere. So a lot of times it will leak out into the lungs, which causes a lot of our manifestations. So with fluid volume deficit, this is hypovolemia. So just like it sounds, there's not enough fluid in the body. It's relatively common, and we often use the term dehydration interchangeably with hypovolemia. It is actually a very serious problem. So water loss of as little as 1 to 2% impairs cognition and physical performance. Loss of 7% of body water can lead to complete circulatory collapse. So some are actual true deficits and some are relative deficits. You don't need to memorize isotonic versus hypotonic versus hypertonic dehydration, but I want you to understand what they are. So isotonic dehydration is a true deficit. So our fluid loss is not balanced by intake, and the losses of sodium and water are in proportion. So this is the type of dehydration that's commonly manifested through vomiting and diarrhea. Hypotonic dehydration, this is when you lose more sodium than water. So our serum sodium is below normal limits, and you have a compensatory shift of fluid from the extracellular to the intracellular areas in an attempt to equalize. So this actually leads to even greater cellular dehydration. It can result from severe and prolonged vomiting and diarrhea, or from burns or renal disease. The risk is increased if you replace the patient's fluids with fluid that does not contain electrolytes, because in that case you're just adding to the volume without increasing the concentration. So hypertonic dehydration, this is when you lose more water than sodium, so the serum sodium level is above normal levels. So we have that compensatory fluid shift from the intracellular to the extracellular space. So the extracellular volume remains fairly normal, which delays the signs and symptoms until the dehydration is quite serious. This condition is going to result from health problems like diabetes insipidus, administration of IV fluids, or sometimes if we give tube feedings with really high electrolyte levels. Now typically it's rare for only one type of dehydration to occur, which is why we don't commonly refer to dehydration as isotonic, hypotonic, or hypertonic. And the body is constantly attempting to compensate by shifting fluid and electrolytes from one compartment to another, so frequent assessment is really crucial. Okay, so some of our causes of fluid volume deficit: decreased cardiac output. So our cardiac output is decreased because of the lack of circulating blood volume, which leads to our symptoms. So if you don't have good cardiac output, you're not going to have good circulation. We're going to see hypotension, tachycardia, tachypnea, weak pulse, and because our kidneys are not being perfused the way they need to be, we'll also see reduced urine output. We may have inadequate fluid supply to tissues. So if we have a lack of blood volume, this is going to lead to an inadequate tissue supply. If you look under the manifestations, it lists a hematocrit increase. Why would your hematocrit increase when you have a fluid volume deficit? So it's not a true increase. It's just that your hematocrit becomes more concentrated because of a lack of overall fluid. So you've lost the water, you've lost the plasma, and so it seems like you have more hematocrit, but it's really just because it's more concentrated. Then the next thing that you might see is third spacing. So this is a relative fluid deficit. The person has not actually lost the fluid from their body. They've just had a shift of the fluid from the vascular space into an area where it's not available to support those normal physiological processes. So the trapped fluid represents a volume loss, even though the fluid is still contained within the body. So typically, it becomes trapped in interstitial tissues, and the patient has a deficit of intravascular fluid. So assessing the extent is difficult because there's no true loss or gain of fluid, but just a shift from one compartment to another. So we see this mostly with edema. The fluid has shifted from the intravascular space out into the tissues. So we haven't lost it, it's still in the body, but it's not in the intravascular space where we can actually use it. So it still represents a fluid volume deficit.